Hello, everyone. I'm Patty Pellikka, Editor-in-Chief of JASE. Welcome to Author Spotlight for the month of December. I have joining me today Dr. Leila Rittey and Dr. Angela McBrien, who are authors of a paper that we will discuss. This work was conducted at University of Alberta, Edmonton Clinic Health Academy. Welcome, Leila and Angela.
Thanks for having us.
Tell me, what prompted you to conduct this study?
So I went to Edmonton for a fellowship in fetal cardiology, and my background training is in the United Kingdom. So I've been working as a pediatric cardiology trainee, and then more recently as a pediatric and fetal cardiology consultant in the UK. Part of the training that I really wanted to develop as a fetal cardiologist was learning more about early fetal echo. And having done a bit of research, I noted that Edmonton really were a leader of early fetal echo, and they were doing an awful lot of it. So I applied to go for a fellowship over there and went across. And when I got there, Dr. McBrien was my supervisor and sort of said, "We're going to do some research. What research would be interested in getting involved in?" And I said that I was really interested in finding out actually about not just doing early fetal echo, but actually, is it worth doing? Do we get good information from it? Is the information that we get from it something that our patients and our families can use and is accurate information? So we're not bringing them for a scan just because we can, but we're bringing them for a scan because it genuinely affects patient care, and it really helps them to be able to make any decisions that they need to, or have more time to research what their child may or may not have. So I was really keen to develop my knowledge on that. So with Dr. McBrien and her team's support, I embarked on this research project.
Well, it's a fantastic study and high volume study center indeed. So you did 1,662 early fetal echoes. And what did you find?
So what we looked at was we wanted to really critically assess the accuracy of the diagnoses that we were making. A lot of the early fetal echo studies, by their very nature, will turn out to be normal. And what we found was that when we say that your fetus's heart is normal at 10 to 15 weeks of gestation, that in the vast majority of those cases on the follow-up study that we always do, the heart truly was normal. Likewise, we had 130 cases with fetal heart disease diagnosed at the early fetal echo study. And we were very interested in understanding whether they truly had confirmed congenital heart disease of the nature that we had diagnosed at the time of the early fetal echo as they went on through for later fetal echo, or unfortunately for some postmortem. And so we had confirmation in many of our cases. We had 35 who had the follow-up. We had 39 who had a follow-up, and of those 35 were confirmed to have the major fetal heart disease that we had diagnosed. So what we concluded from that was that early fetal echo is good and sensitive in diagnosing fetal heart disease, even conducted at these gestational ages, and also excellent at excluding congenital heart disease, so that we know that we're giving families accurate reassurance that their fetus is developing normally. We did find that some fetuses went on to develop progressive heart disease, which is not unexpected. And we find that we think that these data are very helpful. We use them all the time now in our counselling moving forwards to talk to families about what level of confidence they should have in our diagnoses. And we also know that many centres are interested in setting up an early fetal echo service, and I think are scared in many ways, about whether or not they can do this accurately. So we're hoping that these data are useful with our own practice for all of those centres that are either practicing or considering practicing early fetal echo. And and to give them that confidence that what they're doing is able to be accurate and reliable.
And you were able to get follow-up in most of these patients. So you verify that you didn't miss disease, right?
Yeah. We're very lucky that we have quite a captive population here in Edmonton. And we always strongly recommend that people have a follow-up study, whether their echo is normal or abnormal. And we also push quite hard for people to consider postmortem, because that level of quality assurance is very important for a service. And so, yes, we had follow-up in the vast majority of the patients who had continuing pregnancies. Of course, by its nature, unfortunately, when you do an early fetal echo, we did end up not having confirmation in many of the cases, because unfortunately there were intrauterine fetal deaths or termination of pregnancy that impacted the ability then to follow up.
The feasibility of doing the fetal echo at this early time frame, 10 to 15 weeks, is really impressive. How often did you have to do endovaginal studies?
In very few cases, actually. We do a lot of endovaginal scanning for research purposes whenever we're scanning, in much more in the research realm between about 8 and 10 or 11 weeks. We find that that's used a lot more often. But with today's technology and with our sort of evolution of skill over time, we only ended up using endovaginal scanning in a small number of cases. I think it was 14. Leila could correct me if I'm wrong. Sometimes that was because we saw, most of the time I would say that's because we saw what we needed to with the transabdominal approach. And other times, we would have recommended endovaginal and it wasn't, for whatever reason, acceptable to the patient to proceed with that. We did show in our paper that there are incremental benefits of adding endovaginal scanning when the transabdominal imaging is difficult. But for those patients in whom endovaginal scanning was not feasible, then we also demonstrated, quite a large improvement in the score that we were using for anatomical assessment whenever we were bringing the patients back within 1 or 2 weeks for a reassessment. At that stage, the fetus grows really enormously, at an enormous rate, I should say. And so even 1 or 2 weeks can make a very big difference to what you can see and what you're able to counsel on.
Are there certain disorders that are particularly hard to detect and recognize with this exam?
I just think generally with looking at early imaging, it's the smaller structures that are really difficult to see. So things like pulmonary venous return. So often you can get an impression of pulmonary venous return on 2D, but accurately, clearly seeing the colour, because it's just such low velocity at 10, 11 weeks. So accurately seeing the colour in or getting an accurate Doppler of pulmonary veins is very tricky. Equally, branch pulmonary arteries. So they, I think, were the two main things that we noticed that we really did get more information on with mainly our follow-up studies, but also sometimes with adding in the endovaginal scanning. So yeah, I think those two were the main things that we really noticed that we saw more of. Similarly, like clefts in mitral valves. So it was all the subtle things. We found that from very early on, from the 10, 11 weeks, the major diagnoses really didn't change. The sort of overall things, it was the subtleties and like an additional left SVC in a hypoplast. Those little things were the additional information that we were adding. Not sure if there's anything else, Angela, you'd like to.
Well, the nice thing in the paper is with the anatomical score, we sort of segmentally categorized what was seen. So readers will be able to look and see the areas where we were weaker and the areas where we were stronger, and how things changed as, between transabdominal and endovaginal. Transabdominal in the sort of late first, early second trimester versus the standard sort of mid-trimester phase whenever people are scanning. So we tried our best to quantify it to give people a better feel for that.
What are the next steps for your work?
I think it was a springboard for us to really embrace quality assurance. Since we did this work, we realized that we really needed to do this on a rolling basis. This gave us so much data, but But what we wanted was then to move forward with regular quality assurance sessions, and we've done that. So we use a metric to try and understand what we've missed in our service, not just in the first trimester, but also all the way through pregnancy, to try and allow us all to learn from each other's experience, to try and always have a very strong focus on quality, because it's so important for us to be able to provide that for the families we care for.
So part of this work, I think, is to extend the expertise from Edmonton to other places in the world. And Leila, I presume you're doing this work now in London.
So when I first came back from Edmonton, I actually went to a centre in the north of England in Leeds. While I was away in Edmonton, they'd employed a newer consultant there that had started up an early fetal echo program following it. He did some work in a centre in London prior to going there. So we were really able to sort of hit the ground running and push forward in doing lots more early fetal echo, because there was 2 of us there that were really keen in doing that. So that kind of spread out through there. Since I've come to Great Ormond Street, we've been continuing to see patients. The 2 London centres in the UK and Leeds now are probably the 3 centres that are doing more of the early fetal, because they had that bit more of an interest and expertise in doing it. But I definitely feel much more confident having gone abroad and really learnt it from world leaders in being proficient in being able to do early fetal echo, and just knowing the differences in it. It's something that I think you really need to learn it by someone that knows early fetal echo. There are just very subtle differences to mid-trimester fetal echo that really, my experience in Edmonton was really, really helped my future career and hopefully the patients I'm able to look after.
I think we were really enthused when Leila presented this work at the scientific sessions of the American Society of Echo about how much excitement there was around the field. It started off as being quite a niche thing to do, and now, as evidenced by Leila's experience, people everywhere are starting to try and take it on. And, there is a responsibility for us. We can't train everyone who's going to do it, but at least if we get the data out there, then people can understand, what we're doing, how we're doing, and hopefully try and replicate that.
So in summary, early fetal echo, that's at 10 to 15 weeks of gestation, really was highly feasible and allowed accurate diagnosis and exclusion of most early fetal cardiac disease. So congratulations on this work. I'd like to also recommend that our readers check out the excellent editorial by Drs. Flora Gallegos and Anita Boone-Grady in the same issue.
Thanks very much.
Thank you so much.
Thank you, and thanks for publishing in JASE.